B of the cardiovascular system. We're going to look at the cardiac muscle fibers and start off with the macroscopic anatomy. The cardiac muscle cells are striated, they're branched, they're short, they're interconnected. There tends to be just one central nucleus. They do contain several large mitochondria. The T-tubules are wider but less numerous than what you would see with skeletal muscles, and the SR, the sarcoplasmic reticulum, is also simpler than what you would see with skeletal muscle. And there are intercalated discs. These are found only in cardiac muscle cells. They're connecting junctions between the cardiac cells. Basically, they contain desmosomes that help hold the cells together and prevent the cells from separating when they're contracting. And it also contains gap junctions, which, if you remember, allow ions to pass from cell to cell during the contraction, allowing for substances to pass between those adjacent cells. And the intercalated disc, this allows the heart to be able to contract as a very coordinated type of response. The intercellular space between cells has some connective tissue matrix in it and contains lots of capillaries. It's often allowing the cardiac muscles to connect to cardiac skeleton. It gives the cells, when they're contracting, something to push against. So in this diagram, you can see first the histology, an actual picture of the cardiac muscle cell. Those dark lines you can see are the intercalated disc. And like I said, that is something that's unique to cardiac muscle. So if you're looking at a slide and you see the striations, you know it's either skeletal muscle or cardiac muscle. But then if you see the intercalated disc, then definitely it's cardiac muscle. If you see branching, it's cardiac muscle. And then the schematic drawings do show those gap junctions and the desmosomes. And this is an enlarged picture showing, number one, the branching that you see, the intercalated disc. You do have one large nucleus, usually per cell. Remember, skeletal muscle often is multinucleated. You have the sarcolemma, which is that membrane, the cell membrane essentially around the muscle cell. And then you do have the striations, which is due to the I band and A bands alternating. So when you look at muscle physiology and compare between skeletal muscle and cardiac muscle, is it the same? Is it different? Yes and yes. There are some similarities. The contraction is going to be preceded with depolarizing action potential. Remember, depolarization is going to bring that charge to a more positive charge. The depolarization wave is going to travel down those T-tubules. It's going to cause the sarcoplasmic reticulum to release calcium. And there's going to be some coupling that will occur in terms of the calcium binding to tropism. Sliding fullness. Now, some of the differences are that cardiac muscle cells are self-excitable. So there's contractile cells and pacemaker cells. Contractile cells are responsible for the actual contraction. And the pacemaker cells, these do not contract, but they will depolarize spontaneously. They initiate or begin the depolarization of the entire heart. So they're the ones that, so the name implies, it sets the pace for the contraction to occur. There is not a stimulation from the nervous system. It's the pacemaker cells that are going to be regulating the contraction process. The heart is going to contract as a unit. It's kind of an all or nothing. This allows for a much more effective and much more efficient type of pumping action, uh, and you get ultimately then a stronger pump, if you will, more force to push that blood out of the heart. The influx of calcium from extracellular fluid is what triggers the release of calcium from the sarcoplasmic reticulum. You're going to have depolarization is going to open some of your calcium channels, allowing calcium to enter the cell. And then the extracellular calcium releases sarcoplasmic reticulum to release its intracellular calcium. Tight contractions cannot occur in cardiac muscles. The cardiac muscle fibers have a much longer absolute refractory period than the skeletal muscles do. It prevents any type of contractions from occurring. It's allowing the heart to relax and fill up so that it can act as that efficient pump. You don't want it to just fill up halfway. It's giving enough time so that it can fill up completely when the next contraction occurs and for it to pump that blood out. The heart's going to rely on aerobic respiration. It has a lot more mitochondria than skeletal muscle, and so if it's aerobic respiration and you're using a lot of ATP, remember then that means it is dependent on having oxygen present. So if oxygen is not there, it's not going to work. Skeletal muscle, if oxygen is not present, can carry out fermentation process to produce the ATP that it needs, but cardiac muscle will not carry out fermentation. This table is illustrating the differences between the skeletal and the cardiac muscle. So what's happening in the heart in terms of the electrical processes? Well, the heart's going to depolarize and it contracts, as I said, without any type of stimulus coming from the nervous system. Now, the rhythm, the rate at which it's pumping, this can be altered by the autonomic nervous system, but it's not being. The intrinsic conduction system is a system within the heart that's setting that basic rhythm of the pumping. It's going to coordinate that heart beat. It's a function of the gap junctions in what we call the intrinsic cardiac conduction system. It's going to start with the non-contractile cells, the pacemaker cells. They're going to start the process, basically think of it as start this electrical current and then distribute that impulse in a very coordinated fashion throughout the heart so that depolarization occurs with contraction. So the pacemaker cells, they have essentially an unstable resting potential, and we refer to that as the pacemaker potential. The first step or the first portion of it is that what we call the pacemaker potential. Your potassium channels are closed and the slow sodium channels are open. Because of this, the interior starts to become more positive. Typically it's negative inside the cell, but those slow sodium channels are open, so the sodium's slowly moving in the cell more positive. Then you have the depolarization. This is when the calcium channels open. This can be about negative 40 millivolts. Once those calcium channels open, you have a huge influx of calcium that's going to lead to the action potential. You have all this plus charge moving in. And then repolarization is when the potassium channels open, and that is allowing, remember, potassium is usually higher inside the cell, so it's going to flow out. So that positive charge is flowing out, returning the cell to become more negative. This is showing on this graph that in step 1, you've got that pacemaker potential, so sodium slowly moving in, potassium gates close. And then if you follow the line, it's becoming a little bit more positive. Reaches about -40, that's depolarization, that action potential begins. Boom, they reach that threshold point. Influx of calcium due to the calcium gates opening. So you're becoming even more positive. And then number 3 is the repolarization with the closing of the calcium channels and the potassium gates now opening. So the potassium, that positive charge, is now moving out. And that just keeps repeating, as you can see. The cardiac pacemaker cells, so they initiate the impulse. They're going to pass that impulse in a very regulated fashion across the heart. It's going to take about 0.22 seconds. The direction that it's going to take is from the pacemaker cells to the sinoarterial node, to the atrioventricular node, to the atrioventricular bundle, from there to the right and left bundle branches, from there to, it used to be called Purkinje fibers, or the subendocardial conducting network. So at the sinoarterial or SA node, it's the pacemaker. It's located in the right arterial wall. This can depolarize faster than the rest of the myocardium. So it's going to generate this impulse. And the impulse is going to spread across the right atrium to the AV. The atrioventricular node is in that inferior interatrial septum. That septum that's between the right and the left atrium. The impulse is delayed about 0.1 second. Why is this? Because the fibers are smaller in diameter, there's fewer gap junctions. And this is going to allow for the atriums to contract before the ventricular attraction occurs. The atrioventricular or AV bundle, this also is known as the bundle of His. This is the only connection between the atriums and the ventricles because there's no gap junctions between them. So this is the only way that electrical impulse can travel from the atrium to the ventricles, is through this bundle of His. It's located in the superior interventricular septum, and then you're going to have it spread to the right and left bundle branches. Those two pathways, they're in the interventricular septum. They're going to carry that impulse down towards the apex of the heart. And from there, it's going to go through the Purkinje fibers. The pathway is a little more elaborate on the left side of the heart as compared to the right side of the heart. The ventricular contraction is going to occur immediately following. It's going to flow from the apex, so that point at the bottom of the heart, up towards the atrium. So in this diagram here, you can see in milliseconds on the graph on the right, it's comparing the action potential shape at the various locations. But on the left-hand side with the heart, you're seeing first the SA node, these pacemaker cells. As you can see, as I said, it's in the right atrium. And that electrical impulse is going to spread across the atrium. It will spread from the right atrium to the left atrium, and then it will stimulate it at the AV node. There's a slight pause there, and like I said, that allows for the atrium to contract a little bit before the ventricles to contract. From the AV node, it's going to travel down, follow it down the AV bundle. We have it branches, and the bundle branches, so one branch is going to go and stimulate the right ventricle versus the other branch is going to spread down and then stimulate the left ventricle. They move down, the bundle branches down throughout the ventricles. And so the charge is the contraction the stimulus so that it contracts together as a single unit to the ventricles, and that contraction is going to go from the apex up and move up. If there is a disorder or a defect with the intrinsic conduction system, you're going to typically have an irregular heart rhythm or irregular heart contractions occurring. Arrhythmia is an irregular heart rhythm. You have uncoordinated atrial and ventricular contractions. Fibrillation is rapid, very irregular contractions. The heart, because it starts pumping very irregularly, and the efficiency just drops. It essentially becomes like a broken, useless pump. It's still pumping, but if those contractions are too fast and if they're not coordinated, you're not pumping the blood in an efficient manner. And essentially, the circulation or movement of that blood may cease, which is going to result in brain death because you're no longer supplying the nutrients and oxygens as you're supposed to. How do you treat fibrillation? Defibrillation interrupts that twitching, kind of let's give a shock to start and get it back into a regular, normal rhythm. At times, if the AV node takes over, it can set the rhythm, what we call junctional rhythm. And it's a way of taking over in case the SA node is abnormal. Those pacemaker cells are abnormal and not contracting properly as they should. Like I say, you need to have the most efficient pump as possible. Sometimes there's extrasystole, which is essentially going to be where there's a small part of the heart. It's going to trigger an impulse before the SA node can, and so you end up having delay. The heart takes longer to fill, and so the next contraction is felt kind of as a thud because there's more volume of blood that has to be pushed out. That can be caused by excessive intake of caffeine or nicotine. So in order to reach the ventricle, the impulse has to go through that AV node. If the AV node is defective, then the impulse is not going to reach down to the ventricles. And so basically, you're not going to be able to have the proper circulation or adequate circulation that you need. Treatment for that is to put in an artificial pacemaker, which is going to work to basically reconnect the atrium and the ventricles again. You get efficient pumping to occur. Extrinsic innervation of the heart. This allows for the heartbeat to be modified by the autonomic nervous system. Usually it's going to be controlled in the medulla. The cardiovascular center will send signals to, if the sympathetic vision is turned on, to increase the heart rate and the force. How does it do this? It's going to stimulate both the SA and the AV nodes. It's going to stimulate the heart muscle. It's going to stimulate the coronary muscles. All of this is to increase that blood flow, so you increase oxygen to the muscles where you need it to have your response that typically is seen with the sympathetic nervous division. The cardioinhibitory center is when the parasympathetic signal is going to send a message to the vagus nerve to decrease the rate. How does it decrease the rate? It inhibits the SA and AV nodes. Slows everything down. Remember, sympathetic is fight or flight. Parasympathetic is rest and relax. And so this is showing how the various nodes can be stimulated by either parasympathetic or sympathetic neurons, depending on what the situation is, at any particular time. So they can adjust the rate, but there's initial contraction. That's by the pacemaker cells. Contractile muscle fibers are those that make up most of the heart and are responsible for that pumping action that you see. With the generation of the action potential, depolarization opens fast voltage-gated sodium channels. Sodium is going to rush into the cell. You have that influx of it. Feedback is going to be positive feedback in that you have the positive, initially about a negative 90 millivolts. And as that sodium is rushing in, more rushes in, and you keep increasing towards a more positive charge for the depolarization by sodium is also going to involve your calcium channels. Those will open. And so at about positive 30 millivolts, the sodium channels are going to close, but the slow calcium channels are going to remain open. So you're still having an influx of the positive charge. This is allowing the depolarization to last longer. If you were to plot this out, what does it look like? It looks like it's plateauing. After about 200 milliseconds, the slow calcium channels are going to close, and then the voltage-gated potassium channels open. So now what happens is you have the potassium, remember it's higher inside the cell, so it's going to be moving out. So we refer to it as efflux. It's moving out of the cell. So positive charge moving out of the cell is responsible for the repolarization. It's returning that cell back to that resting membrane potential, which is a negative charge. Calcium is going to be pumped back into the sarcoplasmic reticulum and also be pumped out of the cell into the extracellular space. That's also going to help return the cell to resting, getting that positive charge out of there. Some differences between the contractile muscle fiber of the heart and skeletal muscle fiber contractions is that the action potential in the skeletal muscle lasts for about 1 to 2 milliseconds. In cardiac muscle, it lasts about 200 milliseconds. The contraction of the skeletal muscle lasts for anywhere from 15 to 100 milliseconds. In cardiac muscle, the contraction lasts over 200 milliseconds, much longer. So what's the benefit of a longer action potential, a longer contraction period? Number one, you get a very strong contraction and you're getting a very efficient pushing of that blood out of the heart. The longer refractory period prevents the type of the and so here you can see the depolarization followed by number 2, the plateau that has to do with the calcium influx through the slow channels, and then slowly returning back, the repolarization. An electrocardiograph can measure the electrical currents that the heart generates. The electrocardiogram is referred to as the ECG or EKG, is the graph that's recording that. And you get typically a printout of that electrical activity so that you can actually look at the pattern, look at the amounts, and take various measurements from it. It's not going to be a tracing of a single action potential, but a combination of all of them. To do an EKG, you're going to place electrodes on various points on the body. There's usually 12 that they will place, and so they can monitor the different voltage differences placed. When you look at the EKG, there's certain components that you should be able to recognize on there. There's a P wave. This is, at the beginning, it's depolarization of the SA node and atrium. Then you're going to have a QRS complex. This is the ventricular depolarization as well as the atrial repolarization. And then after that will be the T wave, which is the ventricular repolarization. So they occur on the graph in this order, the P wave, then the QRS complex, and then the T wave, so that you can follow that pattern of the depolarization of the atrium. The atrium's repolarized while the ventricles are depolarizing, and then the ventricles repolarize. The P to R interval is the beginning of the atrial excitation to the beginning of the ventricular excitation. And then S to T segment is when the entire ventricular myocardium is depolarized. And the Q to T interval is the beginning of the ventricular depolarization all the way to ventricular repolarization. So if we look at a classic normal EKG tracing pattern, as you would see printed out, you can see if we start from time 0, and then that first little peak, little blip, that's the P wave. That's when the atriums are depolarizing. Then it returns back to about baseline, then it's going to dip below the baseline, then suddenly peak, and that's the Q, and then suddenly peak way up, that's the R, and then dip down, and the lowest peak then is the S, that's your QRS complex. And then should return to baseline for a bit, and then you have another peak, which would be the T wave, which is the ventricular repolarization. So in this sequence, it is showing what is happening in terms of the depolarization and repolarization of the atriums versus the ventricles, how that charge is passing from the SA node to the AV node down through the bundles of His to Purkinje fibers, and it's correlating it to the tracing or the pattern on an EKG tracing. So you can relate what's happening in the heart, where the charges, where's the depolarization, where's the repolarization, with the EKG tracing. If there's a change in the pattern or the timing on an EKG, that can indicate a couple of things. There may be damage to the heart. There may be disease to the heart. There could be some problem with that heart's conduction system. So you can look at it, and depending on what you see, give you a clue as to what's going on with the patient and what type of disorder is going on. Some problems can be detected simply by looking at the EKG. If there's an enlarged R wave, that might indicate enlarged ventricles, just as an example. You can often look to see if there's any type of arrhythmias occurring on here, any type of maybe flutters, because that will all be picked up. And it's not invasive. You put the leads just on the surface of the skin, and we can pick up these electrical impulses. Why is it possible to do that? Is because, remember, our bodies are over 60% water, and dissolved in the water are the electrolytes, the ions, the sodium, the potassium, the calcium, etc. Those are ions, and they do transmit electrical impulses. So just on the surface, we can put the lead, and it will pick up those electrical charges. This is showing a young infant. They are performing an EKG on, as you can see, all the electrodes that are placed on the chest. And here is a normal, we call it sinus rhythm. So you can easily see the first little blips, the P, and then you've got the QRS, and then followed by the T, and then it starts over again. Nice, steady, consistent, regular heartbeat, the spacing between each of those, and oftentimes it's easiest to measure from one R to the other R. The spacing between them is very consistent, so that tells you it's a very regular heart rate. Junctional rhythm, in this case, SA node is non-functional. because of that, you can look and see that there is no P wave. And so the AV node is pacing the heart at about 40 to 60 beats per minute. And obviously, as compared to the previous one, the pattern is not the same. Here's another example of an abnormal EKG. As a result, here you've got more P waves than you have QRS waves. It looks like there's usually about 2 P waves for every QRS, and the timing of it is much longer between. Ventricular fibrillation, here you can tell that the electrical activity, to say it's disorganized is an understatement. It's all over the place. The action potentials are just randomly occurring. You would not be having an efficient pumping action occurring. This person is suffering right now a heart attack, and you need to shock and get that back into a regular. So what are some of the mechanical events that are occurring in the heart? When you have heart contraction, it's systole. When it's heart relaxation, is diastole. The cardiac cycle is that blood flow through the heart during one complete heartbeat. So you're going to have the atrial systole and diastole and ventricular. And we can measure those pressures and volumes of the diastolic and systolic pressures. In the cycle, you're going to have different pressures, different volume of blood changing occurring in here. And you can follow some of this on the EKG. 3 phases. Well, number 1, ventricular filling. This is the mid to late diastole. The pressure is low. Blood is flowing from the atrium through those AV valves into the ventricles. Your semilunar valves are going to be closed, so the blood as it flows from the atrium down to the ventricles, it's going to remain in the ventricles. Atrial depolarization then triggers atrial systole, or the P wave. This is when the atria contract, and it's going to push the remaining blood into the ventricle. Now, about 80% of it is just going to flow passively, and only 20% of it remains to be pushed during the contraction of the atrium. End diastolic volume, or EDV, is the volume of blood in each ventricle at the end of the ventricular relaxation or diastolic section. Depolarization spreads to the ventricles. That's going to be the QRS wave. The atrium finished contracting, and they're going to return to the diastolic phase or the relaxation phase, and then the ventricles are going to start. Ventricular systole, the atriums now are relaxed, ventricles start to contract. As the ventricles start to contract, the pressure is going to increase in the ventricles, and that causes the AV valves to close. During the isovolumetric contraction phase, all valves are closed. Then that's going to be followed by the ejection phase, which is when the ventricular pressure starts to exceed. It's higher than that in the large arteries, the pulmonary trunk and the aorta. Because the ventricular pressure is higher, it's going to force the semilunar valves to open. So this is the ejection phase. End systolic volume, ESV, is the volume of blood remaining in each of the ventricles after. Isovolumetric relaxation is going to be very early diastolic phase. Following the ventricular repolarization, that's the T wave, the ventricles are now relaxed. The atriums are also relaxed. They're filling up with blood. The backflow of blood in the aorta and the pulmonary trunk will close those semilunar valves. The ventricles right now are totally closed chambers. because now all 4 valves are going to initially be closed. When the atrial pressure now rises or exceeds that in the ventricles, then it's going to force the AV valves to open. And then you start over again. Blood flows from the atrium down to the ventricles. And you just keep cycling through this process. This figure, I know it looks really busy, but it's actually a very good figure in that on the very top section you have EKG. And it's showing you with the P, the Q, R, S, the T, and then starting over again on the end. You can relate that with the sounds if you're listening to on a stethoscope. The first sound, the second sound, that lub-dub. Down the next part of the graph is looking at the pressure, and it's comparing the pressure like along the aorta and the ventricles versus the atriums, and you can see how it's increasing and decreasing. It's also looking at the volume in the ventricles. And then the next section is looking at the valves, which is very interesting for you to follow. It hopefully will help piece everything together, as well as the pictures on the bottom of when the ventricles are filling, which valves are open. Well, you don't want the blood to just run right through. So as the ventricles are filling, the semilunar valves have to be closed. If blood is flowing from the atriums down to the ventricles, then the AV valves have to be open. Pressure builds up enough, forces the AV valves to close. That increased pressure is what forces now the semilunar valves to open, and so now as the ventricle contracts, you're going to be pushing the blood through the semilunar valves out into the respective arteries. There's a short time period there where all 4 valves are closed. Then the AV valves open up. While they've been closed, the atriums have started filling up with blood. So when they do open up, then they start to fill the ventricles again. It pieces everything together. And if you take the time to sit and look at this, hopefully you can start to see how all the pieces are falling into play here. To make sense to you. CO, or cardiac output, this is the volume of blood that's pumped by each of the ventricles in 1 minute. It can be calculated by the heart rate times the stroke volume. The heart rate is the number of beats per minute, and the stroke volume is the volume of blood that's pumped out of one ventricle with each beat. Normal cardiac output is about 5.25 liters per minute at rest. And so this is showing you that on average heart rate's about 75 beats per minute, stroke volume's about 70 milliliters per beat, and so you just multiply the two, and that's how it came up with 5.25. In terms of regulation of the pumping, the maximal cardiac output is about 45 times resting cardiac output in non-athletic people. The cardiac output, the maximum amount, can be much higher than that in athletes. They've got the training there. Cardiac reserve is the difference between the resting and the maximal cardiac output. So how does that cardiac output change, increase or decreases if you change either the stroke volume or the heart rate? So this is just going through some of the different volumes. This is the stroke volume, and mathematically how you can look at how if you have a longer time in diastolic stage, that can affect some of the volumes. there are three main factors that will affect what that stroke volume is going to be. It's preload, afterload, and contractility. Preload refers to what is the degree of stretch that the heart muscle has. There are different formulas that you can use to look at this. Basically, at rest, cardiac muscle cells are going to be shorter than the optimum length, and so this basically increases the force at which it contraction that you can have. Slow heartbeat and exercise can increase the amount of venous return, which plays a role with the preload. That can increase the stretching ability of the ventricles, which in turn increases the contractile force. Contractility is strength of at any given muscle length. What is that contractile strength of it? Sympathetic epinephrine releases. When it's released, what it's going to do is help to stimulate the influx of calcium, which leads to more cross-bridging formation. Basically, increases the contractility. Acidosis, which is an excess of hydrogen ions, and increase in extracellular potassium, calcium channel blockers. These have a decrease effect. And this is just an example of showing with norepinephrine how it can increase that heart contractility and the effect that it has on increasing the amount of calcium. Afterload is the amount of pressure, what we call back pressure, that's exerted by the arterial blood. What is the amount of pressure that the ventricles have to overcome in order to eject the blood? There is going to be blood in all the blood vessels. So even though you have just pumped blood out of the heart and into the arteries, does that mean now when the semilunar valves close, does that mean on the other side right there on the arteries that it's empty? No, because you always have this blood flowing. So there's going to be pressure of that blood pushing back on the semilunar valves. Pressure is greatest in the aorta. There is pressure with the pulmonary trunk, but not nearly as high. In an individual who has hypertension or high blood pressure, this afterload is increased. That's going to have an effect on things such as stroke volume. So this is just showing how all of the factors that can play a role in helping to determine what that cardiac output is. If the stroke volume decreases because there's been a decrease in the blood volume or there's a weakened heart, the cardiac output can be maintained well by increasing the heart rate, increasing contractility. So there are different things that can affect this. Positive factors will increase the heart rate, negatives are going to decrease the heart rate. Now, heart rate can be monitored by many different things. The autonomic nervous system is going to be monitoring it, various chemical factors. So the autonomic nervous system, remember the sympathetic nervous system can be activated. That's when you're under stress, that fight or flight. And what happens, it releases norepinephrine, which is going to then bind to receptors on the heart, and it can trigger the pacemaker cells to start basically firing rapidly. That's going to increase the heart rate. Now, parasympathetic nervous system does the opposite. It's going to slow it down. Acetylcholine hyperpolarizes the pacemaker cells. Remember, hyperpolarization is when it becomes even more negative, getting even further away from generating an action potential. Basically, it's going to slow the heart rate. The parasympathetic is going to be the main influence on the heart rate. It will decrease that heart rate slower, and then you do have other effects that are going to play a role in the heart rate. When the sympathetic division is activated, then the parasympathetic is going to be inhibited. So one's inhibited, one's activated. There is what's known as the atrial reflex, the sympathetic reflex. It's initiated by when you have increased return to the heart. That means you're going to result with increased atrial filling. What happens here is the atrial walls then are stretched because you have increased volume. That stimulates the SA node, which then increases the heart rate, basically to try to. So once again, heart rate, stroke volume are going to influence cardiac output. Hormones that can help regulate the heart rate from a chemical standpoint would be epinephrine, tends to increase the heart rate. Thyroxine increases the heart rate. Various ions, such as calcium and potassium, they must be maintained at proper concentrations in order to keep that normal heart and functioning in the best efficiency, etc. If those ions, the calcium and the potassium, if they basically get out of whack, if they are not maintained within those homeostatic ranges, too much or too little, that imbalance can cause very serious problems with the heart because of the role that they do play with the whole depolarization and repolarization. Hypocalcemia will depress the heart rate. Hypercalcemia increases the heart rate. Hyperkalemia is going to play a role and alter that electrical activity that can lead to cardiac arrest. And hypokalemia results in a feeble heart rate. You end up with some other factors that can influence the heart rate: age. Fetus has the fastest heart rate. As we get older, it starts to slow down. As a lot of things slow down as we age. Gender plays a role. Females tend to have a faster heart rate than males do. Exercise, typically when you exercise, that's going to increase your heart rate. Now, if you are a trained athlete, you tend to have a slower heart rate. Body temperature. Heart rate increases as the body temperature increases. And likewise, if the body temperature decreases, what are some clinical manifestations? Tachycardia is an abnormally fast heart rate. It is considered as tachycardia when you have more than 100 beats per minute. If this is persistent, it can lead to fibrillation, where the heart goes into kind of that chaotic, irregular heart beat, and you need to get it back on track. Brachycardia is a slower heart rate than normal. It's usually defined as less than 60 beats per minute. In non-athletes, it can be a sign that the heart rate's too slow. You're not pushing that blood fast enough through your system, and the end result is the tissues are not getting the oxygen and nutrients they need in the timely manner. Now, if you're a trained athlete, oftentimes, as I said, the heart rate may be slower, and that has to do with endurance training. Congestive heart failure is a progressive condition. The cardiac output is very low, and becomes low enough that the circulation, it cannot keep up with the needs of the tissue. And so you're going to have other ramifications throughout the body due to this, because once again, they're just not getting enough oxygen, they're not getting enough nutrients, you're not getting rid of the waste products. Why? Because the blood is just flowing too slow. the heart is weakened. It cannot keep up. It may be also due to clogged arteries. Over time, there may have been fat buildup, and that's interfering. The clogged arteries and the fat buildup is interfering with the blood flow. And so, once again, you're not getting the adequate nutrients and oxygen to the cells that need it. So the heart's not working effectively. Persistent high blood pressure. This is where the heart's basically having to exert more force. It's working harder than it should. And it causes, over time, if it's sustained very high, the myocardium, that muscle, cardiac muscle, starts to get weaker. Multiple myocardial infarcts, the heart becomes weak because what has happened is the contractile cells, when they have become damaged, essentially from a heart attack, they are being replaced with scar tissue, not with contractile cells. And so overall, the heart's going to become weaker. Dilated cardiomyopathies, when the ventricles stretch, they become flabby, the myocardium starts to deteriorate. Drugs may play a role in that. Chronic inflammation can also play a role in causing that. With congestive heart failure, either side of the heart can be affected. Usually what happens with the left side failure of the heart, so the left side's not pumping efficiently, it results in pulmonary congestion. In other words, the blood starts to back up in the lungs, because if the left side can't pump effectively to send that blood to the systemic circulation, where's the blood arriving to the left side from? It's coming from the lungs, so it starts to back up in the lungs. If you have right side failure, it results in peripheral congestion. Once again, the right side's not able to keep up as the blood is returning from the systemic circulation, and so the blood is going to start to pool in various organs, causing edema. Either side failure is going to affect ultimately the other side. So if you have left side failure, you're going to have the blood back up in the lungs, and if it's backing up in the lungs, and furthermore it backs up and it's going to start to weaken the right side of the heart. And if the right side has failure and the blood's pooling in the systemic circulatory system, then it's ultimately going to be affecting the left side. So you have failure on one side, and what happens is it's going to ultimately weaken the entire heart. Initially the one side, but then ultimately the entire heart will be weakened. What is the treatment? Number one, try to remove the fluid, either in the lungs or in whatever body organ where you have the edema occurring. You can give drugs to try to reduce that afterload and increase the contractility of. What are some of the developmental aspects of the heart? As development occurs in the embryo, the heart tube it starts out as a tube, and it kind of shifts and moves around, twists around. You have structural changes, and eventually by about day 35 after fertilization, you have the four-chambered heart. The fetal heart, I say by day 35, it's formed. It's the four chambers. It starts beating. The fetal heart has certain structures that will bypass the pulmonary circulation, because the mother's providing oxygen and is getting rid of the CO2 waste. The mother's providing all the nutrients. And so in terms of having that gas exchange occurring, the lungs are not functional. Yes, they have a blood supply to keep those tissues living and get the nutrients they need, but they're not functioning in gas exchange. So the foramen ovale is that opening we mentioned at the beginning that has basically a connection between the right atrium and the left atrium. So that blood coming in, it's like, why go to the pulmonary circulation? Some blood will go through there, but not all of it. Let's bypass it. Just go from the right atrium to the left atrium. In adults, after birth, this hole essentially is closed. That's often what people refer to as, you hear of a newborn with a hole in the heart. It's usually that this has not sealed properly at birth. The remnant's called the fossa ovalis. The ductus arteriosus is a connection between the pulmonary trunk to the aorta. This will also close shortly after birth, and it was another bypass. So blood going out the pulmonary trunk could go through the ductus arteriosus directly into the aorta. The remnant of that after birth is called the ligamentum arteriosum. Congenital heart defects are some of the most common birth defects. They can usually be corrected with surgery. Sometimes it's an issue where you have mixing of oxygen poor and oxygen rich blood, that there may be a defect in the septum. It could also be due to narrowed valves, and that causes the heart to have to work harder to pass the blood through these narrowed valves. So there's surgery that can be used to correct both of these. This is showing some of the examples of most common congenital heart defects. In A, you have a septal defect in the ventricles, and so basically it's a hole in the wall, the interventricular septum between the right and left ventricles, and so some of the blood is mixing there. Once again, oxygenated versus deoxygenated blood. The B is showing a narrowing of the artery, and so that's causing increased work for the left ventricle because it's got to push all that blood volume, but there's a narrowed passageway there. And then tetralogy of Fallot is where you have multiple problems occurring here, in that the pulmonary trunk is too narrow, the pulmonary valve is not closing properly, you have a right ventricle that's atrophied, hyperatrophied, the ventricle septum defect, so you have a hole there, and then the aorta opens from both of the ventricles. So you have multiple problems, but like I said, surgery can correct this. What are some of the changes in the heart that's age related? In other words, as you age and you get older, we talked about developmental and problems that can occur with the newborn. Well, now at the other end of your lifespan. Regular exercise will help keep your heart healthy. Some changes that can occur are things like sclerosis or thickening of the valves. That can lead to heart murmurs. You can have decline in the cardiac reserve. The heart becomes less efficient as a pump. You can have stiffening of the heart, arrhythmias, and plaque buildup. Some of this can be prevented, or certainly the risk factors decreased, by having a good diet and good healthy lifestyle.